morning to everyone, and thank you to see some faces here in the morning, 9 o'clock, Sunday, Delhi, difficult crowd, right? So, first of all, thanking Dr. Anirban as always for giving me this opportunity, and it becomes very difficult to speak in front of senior people like you, Dr. Rangappa, and try to do a decent job at least. So, I'd like to welcome my panelists. Do we have the slides of the panelists? Do we have the slides?
CV वाली slides. Next.
So our first panelist is Dr. Ankit Sharma. He is a professor at the GB Pant Hospital. A very dear friend for many years. Next panelist is our Dr. Justin Aryabhatta Gopal Das. He's a consultant intensivist at Manipal Hospital, around Hospital. And next, I think they don't need much introduction, Dr. Ajit Kumar. He's a lead consultant critical care at Astro Hospital in Bangalore and a vice chancellor in Indian College of Critical Care. Wait up. And our next panelist will be Dr. Irfan Chaudhary. Sir is a professor and head critical care at BMC Sadajang Hospital, New Delhi, and a very dear friend and teacher to us. Wait up. So we can sit on the side. Yeah, we can sit on the side. Absolutely. So great. Can I have my slides, please? So the task given to me was to discuss a case of febrile illness with rash. So for all of those who have made the effort of coming at 9 a.m. in the morning on a Sunday in the Delhi weather, so let me try.
Please invite Dr. Prashant Saxena also. Yes, sir.
A warm welcome to a dear friend, Dr. Prashant Saxena. आप आ जाओ, आप आ जाओ. He is Director of Pulmonology Critical Care at, I think, still Fortis Hospital?
Yes.
Still Fortis Hospital. So now, पूरा fielding set है, अब batting करते हैं. So a case of febrile illness with rash. So the question is it a very important topic to us? So we'll go through some data that what number of patients actually are there who are a diagnostic dilemma who come with a febrile illness, where rash is a diagnostic feature and probably a prognostic feature as well. So to take you through some data, there are a lot of studies who have done over the years in the last almost 3 decades, and I've tried to quote 3 of the biggest ones. One is from UK, though it's a retrospective study, and they had almost 5,000-6,000 patients. Out of them, half of them actually had rash as a part of the febrile illness. And then, interestingly, most of these studies have quoted that the patient who have this condition, fever with rash, tend to have a mortality between 10 and 20%. The only exception to the rule was the CMC Vellore Dr. Poonam Agarwal study, where they said the mortality is as high as 46%. So whenever a study actually stands out of the crowd and you have to look into study, what did they check? How did their data is so different from all the other studies? So here, this is the study done in 2013, and they actually were looking at what is the prevalence of dermatological manifestations in intensive care and what is the mortality related to these presentations. So they actually divided their patients into 4 categories. The first category was patients who had skin manifestations as a part of multi-system disorders. The other category was the ones which developed the rash during the treatment of the critical illness. The third category was the ones who had coincidental lesions, and the fourth category was primary dermatological conditions which presented with the severity of illness needing an ICU admission. Now, what they found was that out of all the patients, the 1,000 patients they studied, almost 42% fitted into one of these categories. And the average mortality, 46%, but the patients who came with a primarily dermatological diagnosis to the ICU, needing an ICU admissions, had a mortality of 65.6%. That is very, very high. And I think probably a part of this is to do with the fact that these are possibly poorly managed, poorly compliant patients with primary dermatological diagnosis who reach to the ICU quite late in the course of illness. And then as intensive as we're not skin specialists, we also struggle with the initial diagnosis and the management. We need our dermatological colleagues to help us, and possibly the spiking high mortality has to do with that. Okay. Now, because this was more of a postgraduate learning, so what we normally struggle with our student is identifying the rash, describing the rash, looking at the onset to the progression of the rash. So I have put in 4 of the commonest dermatological manifestations in intensive care, and we'll discuss how we describe them, what are the differential diagnoses, and the things around it. So this is the first rash that is there, a very, very common rash. Somebody wants to describe from the audience? So my question to Dr. Ankit, could you just help us with the diagnosis and the description of the rash?
This rash typically looks like an erythematous rash covering almost all of the chest and the neck and probably the arms as well. So a diffuse erythematous rash.
Okay. So can you also help us with the possible diseases that actually have?
Whenever you have an erythematous rash, most of the time when you have a skin lesion in an ICU, then you tend to overlook it because the importance of the underlying cause and the systemic effects are overmarred by the other things which are happening to that patient in the critical care. But when you have a patient with such a kind of a rash, erythematous rash, developing and associated with a very high spiking fever, then you obviously want to know what's lying beneath. So as on the slide you can see, there is something called the Nikolsky sign. Now what is the Nikolsky sign? This is something which we have probably read in our MBBS times and skin postings. So if you give a lateral pressure to the skin over a lesion, the epidermis will come off. So coming off of the epidermal layer is called a positive Nikolsky sign, which is present mainly in staphylococcal skin scalding syndrome and toxic epidermal necrolysis. Whereas you can also divide it in 2 types, whether the sign is present or not, then whether the patient is febrile or afebrile. In the febrile group, whether negative sign, the most common reason is out there, that is toxic shock syndrome and Kawasaki disease. And in afebrile patients, it's mostly the anaphylaxis, which is self-subsiding. So this is just a way of, algorithmic approach to seeing a rash and reaching a probable diagnosis. A lot of things further will be elicited in the talk, I believe, Dr. Himanshu.
So that's a very nicely descriptive erythematous rash. The most common seen when you see this rash would be any febrile illness of viral etiology, especially dengue. So when you see the commonest rash, diffuse erythematous, we see in dengue patients. These patients, if they are fair-skinned and you look at their skin during the first 2-3 days when the fever phase is on, there's a blanchable diffuse erythematous rash. Again, it is there in most of the viral illnesses. You just need to look. The only problem is in people who are dark-skinned, it is very difficult to. So I've given the diagnosis on the slide, and I'll request Dr. Ajit to kindly describe and take us to the differential diagnosis.
So it's a kind of a erythematous, some red color rash is there, and macules are, we can just see, and papules are we can palpate. So maculopapular rash. So we can divide them. When you look at the, we can approach them as central distribution and peripheral distribution. So and central distribution again, with fever is there or not. If the fever is present, it is likely it's a viral exanthem or something like Lyme disease, so Bickel disease. And if there is no fever, it could be even a drug reaction. And peripheral distribution, with fever, without fever. And if there are target lesions are there, you think of Stevens-Johnson syndrome. And if it's not there, you may think of, you may consider meningococcemia, syphilis, etc., etc. The peripheral distribution again, flexor extensor. If the flexor acts with the scabies and eczemas are very common, and extensor acts with psoriasis is very common.
Thank you, Dr. Jeet. Just to summarize, if you have a very sick patient with a maculopapular rash coming to ICU with fever, our first diagnosis will be meningococcemia. It is meningococcemia unless otherwise proven, no doubt about it. Okay, and if it is there after the admission to ICU and suddenly you see a patient who's febrile or may not be febrile and develops this rash, this is mostly a drug reaction. So these are the two common reasons for maculopapular rash. Now I'll request Dr. Anirban to kindly look at the rash and describe it for us.
So as we can see that there is both purpura and petechiae. The size is more than 1 millimeter, so it is petechiae. If it is less than 1 millimeter, we will it as purpura. So again, if this it can be due to a number of causes, but most common cause is thrombocytopenia. It is a petechial. Patient may have fever, patient may not have fever. It may be palpable, it may not be palpable, and accordingly the cause will vary. So ITP is a very common presentation which we have seen, and we also have seen, although it is not there in the list, we have seen drug-induced,
yes,
which can also manifest in this form of petechiae. And meningococcemia is, of course, there will be the rash, it will be palpable, and DIC and TTP, it occurs in later stage.
Absolutely.
We don't get in the early
So
stage.
just for the sake of students, you could see that a lot of diseases have an overlapping lesions. So meningococcemia has got maculopapular rash, it also has petechiae and purpurae. So basically you have to look at the dominant lesion that is there and the onset central to peripheral and at what time from the fever the rash occurred. This gives you a very good idea of the type of rash or the etiology of the rash. For example, if you have meningococcemia as a cause of rash, the rash occurs very, very early in the illness, in the first day or two. If you have dengue as a cause of rash, it occurs later in the illness, day 4, day 5, you start getting rash. So the time of onset of the fever to the time of onset of rash also give you an idea of the etiology of this. For most of us, less than 1 mm, petechiae, bigger than 1 mm, purpura, very large, getting together, ecchymosis. Do you feel this is a palpable or a non-palpable purpura for the students? Palpable, non-palpable? Looks fairly palpable, right? If it is palpable, then you look at vasculitis as a possible differential in the disease. Okay.
So, yeah, so Dr.
Yeah.
Himanshu, yeah. No, just looking at the basics. So, one very important aspect of the purpura, petechiae, and ecchymosis are they're non-blanchable because the bleeding has already happened. So, when you blanching is, when the bleeding has not happened, you press the thing, compress the blood vessel, the area may be clearing. But here, with the bleeding has already happened. So, one very important distinguishing feature about the purpura, petechiae, and ecchymosis are that they are not blanchable. Already bleeding has happened in the skin.
Absolutely correct. Okay. So this is a rash. Again, we have given the diagnosis. Dr. Prashant, you like to take a...
Yeah, it looks like a vesicular rash and not a very uncommon occurrence in the ICU patients.
Yeah.
Most likely there are these two bacterial infections and as you have listed, most common causes could be if you have fever or patient. So the common causes are bacterial infections. Usually we see in sepsis patients, and then viral infections are also common. Presenting feature could be in varicella, and we see a lot of varicella patients. Then we know sepsis presents as purpura fulminans, where you have diffuse vesicular rashes.
Absolutely.
And DIC also. Then further, if they are more extensive, then we call them necrotizing fasciitis. And then if the diffuse distribution throughout the body, then bullous pemphigoid and pemphigus vulgaris are the further description of the two.
So most of the commonest vesicular lesions in ICU is varicella or herpes simplex. These are the two commonest vesicular lesions. They don't become bulla, but they remain as vesicles. The smaller size bullas are vesicles. Then in a lot of drug reactions where the skin is scalding, you start getting bulla, and you don't see much vesicle there, but you start getting bulla. And the primary dermatological conditions which have a large bullas, a lot of fluid loss from the skin, they act almost like burns to the skin tissue. These are bullous pemphigoid and pemphigus vulgaris. These both conditions, when they turn up to ICU, are associated with a very, very high mortality. So you should have some decent working knowledge on these skin disorders would uncommonly though present to ICU. Now for the sake of completion, I have just tried to enumerate most of the rashes. So diagnosis starts with the diagnosis of rash. You cannot diagnose a febrile lesion with eye without if you don't know what is the rashes. So we discussed bulla and we discussed vesicles. We have looked at macules and papules. This is a nodule, of course, elevated, most of the nose larger than 1 centimeter. The patch, it's a circumcised flat discoloration. Plaques, pustules, you need to know. Pustules are not very uncommon in ICU. Then this is an allergic wheal, a scale mostly seen in patients who have underlying psoriasis. Psoriasis is relevant to ICU because these patients are mostly on immunosuppressants and they turn up in ICU because of non-dermatological reason of coming in ICU and they're immunosuppressed. So that, if you see this rash, you definitely are you on steroids, HCQS. Okay? Crust, fissures, and then we have excoriations, erosions, lichenification, thickening of skin, and a scar tissue. Okay. Now, my question to Dr. Justin is, if you see a patient coming to your ICU who's febrile for a few days, develops a diagnostic rash, how would you approach such patients?
So, at the end of the day, most of our triage in terms of most of these patients are to do with the sickness, and the sickness is driven either by the primary skin disorder, as you rightly pointed out, or is the consequence of systemic disease presenting as a skin problem. And most of the systemic problems that are like septicemia in as you can see with the dengue, meningococcemia. So the treatment of the cause probably will solve the problem.
Absolutely.
Yeah. Whereas in terms of the CMC paper that clearly mentioned, the delayed skin attention leads to higher mortality. So the concentration there, if you diagnose it as a primary skin problem, then the immunosuppression or whatever that needs, or diagnosing with the skin biopsy in these bullous diseases, how the epithelial, is it immune or non-immune kind of diseases. So that kind of a decision tree in terms of how you approach it in terms of both the diagnosis as well as the framing the question for yourself will usually make the treatment better and probably outcomes better.
Thank you so much. So if you have a patient who comes with a fever and rash, there are two ways to approach them. The first way is this. You look at if the patient developed a rash prior to ICU admission and he came in with a fever and rash, or he developed this after his ICU admission with the ongoing treatment. This broadly classifies you into the etiology. If someone came to ICU with a rash, maculopapular, petechial, purpurate, probably the first few diagnoses would be meningococcemia and dengue, because these are the two commonest conditions that we see presenting to critical care with a fever and a rash. Then it is not very uncommon to see scrub typhus. Scrub typhus is one of the rickettsial diseases, and you tend to see a eschar. You see a eschar. Eschar is basically a necrotic base ulcer with surrounding erythema. The odd part about scrub typhus is that scrub typhus eschar can occur anywhere. We have seen it inside the ear, hidden behind the hairs, in the folds. So to find this rash, you have to unclothe your patient completely and look at every fold of the patient, including the ear and the hairs, everywhere. You may find an eschar, right? When I was training, I was made to understand scrub typhus doesn't occur here. And with Dr. From PGI Rohtak, Dr. Bhalla and Sir, Dr. Dhruv Chaudhary, sorry, I forgot. They present us with data that scrub typhus is very, very common in this part of the country also. Haryana, belts just below the Himalayas in Himachal and here. And once we got to know, we thought we have an epidemic of scrub typhus. Every season we get so many scrub typhus and they respond so beautifully to just doxycycline. You just have to get the diagnosis in time. It's a pulmonary renal syndrome and it fizzles off like beer foam the moment you give doxycycline. Okay? And of course, you have community-acquired staph and strep. The relevance of staph and strep is that these patients don't come as I have staph, I have strep. They come as a post-flu sickness. They tend to have a flu illness, probably with some bronchitis, and then they became very, very sick. They developed a staph or a strep pneumonia, and then they developed a fever and a rash. We recently had a girl, we lost her, who had post-viral streptococcal pneumonia and with empyema. So this is also a very common condition. Then leukocytoclastic vasculitis or hypersensitive vasculitis, also as a post-viral syndrome, is a common presentation to ICU, and then